about 14 to 15% of Jamaican children are born within marriages. Another 51% said they were living with their partners. Mothers, this is also not news, 2/3 of women, this just helps to validate the sample really, because 2/3 of women had had previous pregnancies, and 1/3 of the mothers had had 2 or more previous partners for whom they had had children. Not the current partner, but 2 or more previous partners. We looked at the relationship at birth, and last night we presented a lot of information on fathering. I'm only going to be presenting a snippet of that today. The moms reported that they were in a relationship with 91% of the dads. But as time went on, sorry, I forgot to label that, so that's the 9-month, then the 18-month, and then 4 years. So you can see we start off with the dad being the mother's partner at 91% of the time at birth. By 9 to 12 months, we're at 87.3%. Doesn't fall off that much between birth and 18 months, 87%. But by the time we get to 4 years, we're down to 2/3 of the dads being in a relationship with the moms. Similarly, being the father figure also falls off, but it's a little bit stronger, a little bit more of the dads, even though they are not in a relationship, more of them are still in a relationship. 45% were living with the child at 4 years. You remember Dr. Ashley presented about 45% at 15 years. What we didn't have in that study was exactly when that happened. We knew it happened, but we didn't know when. So here we are a little more accurate in knowing that this is happening by the time the kid is 4 years, that the dad is not in a relationship with the mom. So I'm going to spend a little time on children's physical health. Let me see how many people from the health sector in here. Okay, good enough. So let's talk about children's health. Jamaican parents consistently report that their children are healthy most of the time, which is good to know. Their immunization is provided largely through public clinics, 94%. So the Ministry of Health here is doing a great job. Pediatricians are doing immunization for only 4% of the population. And some are still going to hospitals. For example, the University Hospital has a well child clinic. These are when they're indicating hospitals here, that's what it means, that the hospital has a well child clinic that's functioning there. Accidents and injuries. Kids fall a lot, and at 9 months, they fall really a lot. About 16.4% of parents reported that the children had fallen on the head, and this 9 months means, for the health data, the 9 months means since the child was born and now has the child had this. So it's not that it happened at 9 months, it is during the period from birth to 9 months. The second, the 18 months, is during the period between 9 and 18 months. All right, so it's not at 18 months. Okay, so we're comparing 2 periods. So you can see that between 9 and 18 months, kids fall a bit less. That makes sense, right? Yes, because they've become more stable. I'm not going to have any conclusions at the end of this slide, right? So we're drawing the conclusions as we go. So what is happening there is that they're more stable, so they fall less. And you see that with other falls as well. That drops from 14 to 7.7%. And you see burns and scalds rising because kids are more active. They can reach things more. They can get to things that are harmful and dangerous more. So you see that increasing from 11% to 14%. Burns and scalds are the single largest preventive aspect of childhood injury. And we have a lot of burns and scalds in Jamaica. Fractures remain consistent at 0.5 to 0.6%. We looked at common illnesses. So 1/3 of our babies have colic that the mothers report. Cough. This is interesting that more parents report cough in the first 9 months of life than between 9 to 18 months. In fact, dropping by about a half. High fevers, 39% to 44%. Diarrhea pretty much staying the same. Asthma and wheezing pretty much staying the same. Ear infections increasing a bit, probably increasing with the increase in respiratory infections that children are having. Pneumonias, not that common, and seizures from 1% and 1.9%. Very interesting. 22% of Jamaican children have received home remedies by the time they're 9 to 12 months. Well, let me tell you, this was the most difficult part of my analysis for this presentation. I have never seen so many bushes. I had to go and ask what rice and peas bush is, because that one I never knew of, okay? Then there are the combinations. So some children have gotten 4 or 5 different bushes. And then the parents have told us what the bush is used for. This one for cold, this one for this, honey and garlic, honey and lime, honey and all kinds of. 22% of our children by 1 year have been given some kind of bush to treat some kind of ailment. Interestingly, there was no marijuana reported. We asked parents where did they take their children when they were a little sick. Because, of course, when the child is seriously ill, you need to go to a hospital. So that's not what we were interested in. We were interested in where does a child go when they are a little sick. So we have 9 months, 18 months, and 4 years. You can see that the clinic is the most common choice. It falls off a little bit, though, when the kids get to 4 years. And then that gets picked up by the general practitioners. What is happening here, as you can see, is that the older children are now able to go to the general practitioner. They get old enough, so you see the pediatricians falling off as well. So they take the younger babies to the pediatrician, and then they figure that the general practitioners know enough about the older ones, and then you see that shift. But our public clinics are still doing the mammoth task. We asked about specialist referrals, and children are referred to pediatricians. Only 3.6% of children have been referred from first contact to a pediatrician. The most common referral is to pediatricians, but skin specialists come quite high up there, and only 1.1% get referred for hearing or vision. We looked at, so most of that information that I presented before was obtained from interviews. But because we have the date of births of the children, dates of birth, we could also use administrative data. So we went to all the hospitals and looked through their admission records for all the children that were born in our birth cohort period. And in that period, there were 17,000 hospital visits. This was between birth and 18 months. 17,000 hospital visits. And what you see there is that the mammoth largest number of children are going to Bustamante Hospital. So that's a third of the children that go to hospital go to Bustamante Hospital. And you see St. Anne's Bay there featuring prominently to Cornwall Regional and Mandeville. UHII, 2.6%. When we looked at what the hospital utilization was, more than half of the children that were making contact, it was accident and emergency. Ward admissions was 30%, and clinic was 12.6%. So most of the hospital utilization are emergent conditions that can only be dealt with there. The outcome of admission, the majority of children are discharged with no follow-up required. We have a death rate following admission of 2.3%. 6% are discharged to an outpatient clinic. 0.9% are referred to a specialist or outpatient clinic. We have transfers to another hospital, 0.3%. A small proportion come back for ward review. And we only had one child that was discharged against medical advice. We were able to use this to calculate our infant mortality rate. And our infant mortality rate is there, neonatal deaths, the neonatal rate from the administrative data was 17.9, which, sadly, is exactly the same as it was in 1986. 85% of infant deaths occur in the neonatal period. This is not, this is what is typically known, that the majority occur in the neonatal period. You're going to hear a little bit more about neonatal mortality, not using the administrative data that we use. Let's look at what happens at home. We asked what toys children had at home. And this was a learning point for our interviewers who went into homes with the children. Some of them said that they would never think that every home has toys ever again in life, because some of them were young interviewers, so they were not aware of some of the social deprivation in which children live. So most children had cuddly toys and toys to push and pull around, but only a quarter of children had blocks for building. There was a high proportion of children with books for babies, but this represents a bit of a bias because we gave all our children books at the contact before this. And that's why I put 2 stars there, because that's not normally what we see. But it was one of their gifts when they participated, was a book, a baby book. Musical toys, 78%, but toys for teaching. So if you look, the more cognitive-based toys that teach color, shape, size, numbers and letters and blocks, are the things that are most missing in our homes. In terms of the activities that were done with the children, the first column represents 9 months and the second represents 18 months. And this is activity with the baby most days, which is 4 or more days. So we're singing, and we're singing more to the younger babies. We fall off the singing as they get a little older. Reading, 50% to 57%. Playing with toys, we fall off with that again as they get a little older. Playing games, we fall off again as they get older. So it seems we're spending a little more time, even though we're still at 2/3 in the majority of cases of the children having this interaction daily, we fall off even further by 18 months. We increase with naming things and we increase with counting. And that's because we now are getting ready to prepare them to go to basic school. So we start naming and counting them. 44.4% of parents, we wanted parents to have the option to describe something else. And 44.4% of parents described that they also did something special. And by far, going to buy ice cream was it, right? And also going to buy things. So these are the cultural things that parents do with their children. There are a few that were going to the parks, but ice cream was a big deal. We're going to talk now about school. And this data comes from the 4 to 5-year-old sample. 1 child in 4 had gone to daycare or preschool before being in the basic school kind of setting. Almost everyone is in school at 4 to 5 years. I mean, Jamaica has one of the highest rates of school attendance in the world at this age. The main reasons for not being in school, this was a very few, but the main reasons for not being in school were affordability and disability or illness. How do kids get to school? We have over 2,000 basic schools in the country. Who from the ECC can tell me exactly? It was 2,700 when I was about. Is it still that? You can't walk too far in Jamaica without finding a basic school. But still, children are traveling distances because of the need for the use of a car and a taxi. 40% are able to walk to school. And you see the bicycle. All right? They're on the handlebar of the bicycle, usually very unprotected. Okay? Who makes daily contact with the school? The mother most of the times. The mother takes them to school, or another adult. The father is taking the kids to school 13% of the time. Who is collecting them? The mother drops down a little bit. Maybe she takes them to school on the way to work. We can correlate that information a little bit later. But then somebody else needs to pick them up. So they're being picked up by another adult. This is a parent's report of the child's response to school. So the majority of parents report that their children enjoy going to school. The majority report that they're getting along well with their peers, and only a small proportion have difficulty following the rules or finding the work difficult. And the ones that I scored there were 4 options: always, often, sometimes, never. And the ones that are represented there are the always and often option. So our kids like school, basic school anyway. The parents had their own perceptions of the teacher and the child performance. Really? How many teachers are here? Early childhood teachers? Yes? As they would say, big up yourself. See? The parents are saying that the teachers are excellent. Look at that, 45%. Another 25% very good. Another 20-something% good. So the parents really are engaging with the teachers and think their teachers are good. And they also think their children are doing okay, but not as okay as the teachers, right? In terms of their performance. And these are the concerns that they have about their children in terms of school performance. You know, interestingly, even though they said that their children were doing well, they still had these concerns. 42% for letters and reading, 33% for writing and coloring, 32% for numbers and math, and just 12% for social skills. So they really weren't worried about the social skills. However, the teachers, on the other hand, had some concerns. They thought that just under 8% of children were slow at learning. You notice the difference, right? The social skills were the lowest thing for the teachers, for the parents, but were the highest thing for the teachers, right? Because they have to manage the behavior problems of large numbers. So the behavior problems were just under 10%, and there was a group of other. Homework. Now, children at this age really don't need any homework and shouldn't be getting any homework, yes? However, Jamaican parents reported that the majority of children were getting homework. 88.5% of children were getting homework. Remember, they are 4.5, right? Daily or 2 to 3 times per week. The mean homework time was 30 minutes, but it could go up to 2 hours. Now let's look at how the parents think the homework is adequate. Too little. 18.4%. Just enough, 3/4. And too much, only 5%. So whatever we think, our parents love homework. And, you know, you must think of this positively, culturally, right? Because what it shows is our value for education. That's what it shows. It shows a cultural support for education. And they were satisfied with their schools to a large degree. And I asked them if they knew whether their schools had been inspected by the ECC, and 2/3 of them said yes. A third were uncertain. Only a very, very small proportion said no, and this may be their own knowledge, but 2/3 could report that the school was inspected. So that's great, because they know about the ECC, and therefore, you know, they know what they're supposed to do. Only 25% of children are in extracurricular activities. The majority of the extracurricular activities are taking place at school. And of course, the higher social class children are the ones who are engaging in extracurricular activities. Dancing was by far the most common, and if we know our gender biases in Jamaica, we know that it's the girls that are doing the dancing. And very few boys would be engaged there. And swimming, 15%, and football, another 15%. There was, you know, the art and craft and the music, but they were all very, very little. So this is my job today was to just give you a little snapshot of the lives of our children, how they're spending their time and what they're doing. And after this now, I leave the others to get into the rest of the presentations. Thank you.
Thank you, Prof. Samms. So we're going to hold the questions until after. In retrospect, I should have told you that before, so you can write down your questions, but you can write them now. And then at the end of all of them, we'll call everybody up so that we can have a more fulsome discussion. So we're going to hustle along, and the next presenter is Dr. Olugbuyi, who we simply call Dr. O, who is a man that wears many hats. He is researcher, he is budding cardiologist about to go off and do his fellowship. He is the one that we always come to ask the questions on the ward when we can't figure out what is happening, you know, like in that show House. So today he's going to come to us now and talk to us a little bit more in detail on neonatal mortality in this fabulous cohort. Please welcome him.
Thanks, Abby, for that introduction. How do I change this?
Down.
Oh, okay.
There we go.
All right. Okay. Thanks. So I'll be talking to you this morning just for about 15 minutes about neonatal mortality in JA kids study. So I'll give you a background of the study. All right. Sorry, I couldn't see that. The first 28 days, that's a neonatal period, is a crucial time in a child's life, and that's when you have the highest risk of dying. Every year, about 3 million neonates die worldwide. 50 die in the first 24 hours, so 75 by the end of the first week. Over 80% of this death are attributable to 3 causes: prematurity, interpartum related causes including asphyxia, and neonatal infections. One of the goals of the Every Newborn Action Plan is to end the preventable neonatal deaths and to achieve a target of less than 10 neonatal deaths per 1,000 by 2035. Now, when we look at the perinatal morbidity and mortality survey, 1986, previously quoted to 97 rather, neonatal rate was 17.9 per 1,000 at the time. Early neonatal mortality rate was 16 per 1,000. Late neonatal mortality rate was 1.9 per 1,000 live births, and 56% of the death occurred within the first 24 hours. Most of the deaths were due to immaturity and asphyxia-related problems, at 9 and 35% respectively. Now, a review of the perinatal mortality in Jamaican hospitals done in 2003 showed an early neonatal mortality of 13.7 per 1,000. This excluded the late neonatal mortality at that time. And Professor McCobbins also did a study in 2008 where the neonatal mortality rate was about 16 per 1,000 live births. That study utilized about data from the Registrar General Department, and I think it was about over 40,000 births that were included in the study. The early neonatal mortality in that was 4 per 1,000 live births. Late neonatal mortality was 3.1 per 1,000 live births in that study. If Jamaica is to achieve the goal of neonatal mortality rate of less than 10 per 1,000 live births, it is critical to audit the neonatal outcome to determine the action points for targeted intervention to decrease neonatal mortality. Additionally, with the introduction of the program for reduction of maternal and child mortality, there is a need to establish baseline data against which the impact of the program can be measured. The PROMAC, I stand to be corrected, is a program to really help to achieve lower neonatal mortality rates, and I think came in about 2011, 2012, thereabouts. Now, the aim of our study was to determine the neonatal mortality in 2011 Jamaican Cohort. So, women who were delivered between July 1st and September 30th of that same year, 9,742 were recruited for the JKID study. Descriptive analyses were performed to determine the crude neonatal mortality rate and factors associated with mortality. Now, there were 9,000, in terms of the results, there were 9,670 total live births, 158 neonatal deaths, giving a neonatal mortality rate of 16.3 per thousand, confidence interval of 13.8 to 18.8. Now, this graph shows outcome by birth weight in the JA kids. So we grouped the babies who died into specific weight categories: 500 to 749, 750 to 999, 1,000 to 1.449, and so on and so forth. So if you look at the death of all the children who were born, you will see a steady decline in mortality by the higher your birth weight is. So the bigger the babies, the less likely they are to die. The smaller the babies, the more likely death will occur. Now, this particular graph is showing two things. One is the contribution of the various birth weights to the cohort. So if you look at the first bar graph, and just below it, the line, the ones under 1,000 grams contribute 0.4% to the birth, the cohort, but 20% to the mortality. Again, if you look at 1,000 to 1,449 grams, they contributed 1.1% to the birth cohort, and yet 25% or thereabout to the mortality. And the 1,500 to 2,499, representing 9.5% of the birth cohort, contributed 32% mortality, and those greater than 2,500 contributed about 22% to mortality, although they represented about 89% of total births. Now, when we look at outcome by gestation, whether they're preterm or term infants, the bulk of deaths were occurring in preterm infants, and that was about 7% of preterm infants died, while 0.3% of term infants died. So when we looked at outcome by gestational age, I'm just going to go back up one. So if you look below, you'll see the odds ratio. When you're preterm, your odds is 21.9%, 21.9, with a confidence interval of 14 versus term infants dying. And then for multiple gestations, the odds of dying was 3.8, with a confidence interval of 1.7 to 8.8. So singleton pregnancies had a better chance of being alive. And then when we looked at the outcome by gender, again, unfortunately, boys seem to do poorly from the beginning. Odds ratio of 1.5, which is really pitiful. When we look at the outcome by mode of delivery, the outcome was when you had an emergency section, there was a 3% likelihood of death compared with 1 for elective and spontaneous vaginal delivery. So when we looked at the clinical causes of death, not surprisingly, prematurity represented 53% of the causes of death, followed by perinatal asphyxia, then sepsis, respiratory distress not otherwise specified, and meconium aspiration, in that order. So, well, we following all this data, we now see that there's no real change in neonatal mortality in the last 30 years. In 2011, we're seeing 16.3. In 2008, it was 16.1. 1986, 17.9, and the confidence intervals are there. But I will quickly mention here that how we may have defined certain things may have changed, and especially in 1986, we used a lower bound of about 28 weeks for prematurity, while now we're using about 21? Age of viability was 28 weeks, and now it's 24. Now, we had excess mortality similar to that seen in 1986 cohort. There was still an increased risk of twin death, but in 1986 cohort, the risk was 7-fold. Now is 3.5. An increase in death for prematurity was also seen in 1986, and it's actually much more now because probably of the decrease in age and viability. The most common cause of mortality were prematurity and HIE, which remain the same. However, the proportion of secondary to HIE has decreased. Maybe that's again due to the fact that we have more preterms. But likely, we think this may be an underestimation as the clinical diagnosis. This current study was based on clinical diagnosis rather than by autopsy. Decreased mortality with increased weight, we saw that in data. Disproportionately more extreme low birth weight and very low birth weight was seen. However, infants greater than 1,000 grams accounted for 80%. So when you put groups together, while this group represents about 99.6% of total births, 80% of the death was occurring in that group over 1,000 grams. So to address this problem, we think a stepwise approach to decrease mortality to less than 10 per 1,000 live births. We need to probably first target interventions to decrease the mortality of those neonates greater or equal to 1,000 grams, then targeted intervention to decrease mortality of neonates less than 1,000 grams after we've achieved significant decrease in those over 1,000 grams, where the bulk of the problem seemed to lie. And further studies are needed to identify preventable causes of mortality for larger babies. So if Jamaica is to attain the Sustainable Development Goal of a neonatal mortality rate of less than 10 per 1,000 live births, saying the same thing again, there should be a stepwise approach. Oh well, same thing. Okay, that's it. Thanks.
Thank you, Dr. O. So our two presenters so far, I think, have really whet our appetite with some very interesting information, and I'm sure you're going to have a lot of questions as the afternoon continues. So we're going to continue on our current path of smooth flow, and I'm going to invite Miss Reece, Jody-Ann Reece, who is next up. She is what I would like to call the perpetual student. She's a researcher, and she is one of the major drivers in this cohort study, in fact, along with Prof. Samms at the helm. And she's going to come to us now and talk to us about illness in pregnancy and at 1 year postpartum. Jody?
Okay, thank you, Abby. And I'm here to talk about illness in pregnancy and 1 year postpartum, just to describe the syndromes experienced by mothers in pregnancy and up to 18 months postpartum. So in 2013, the WHO constituted a maternal mortality working group, which focused on defining non-severe maternal morbidity. Because generally speaking, the focus in the work on maternal morbidity is focused on severe acute maternal morbidity, which is also described as near miss. So this essentially means that if you get seriously sick while pregnant or soon after, but you don't die, right? So this study is focused on mostly describing non-severe maternal morbidity. Okay, so we use proxies because it's a self-reported survey, and we didn't have the ability to verify the information. So the proxies that we're going to use are rate and reason for hospital admission in the antenatal and postnatal period, as well as patient reporting of chronic illnesses in the postnatal period. So I won't go over this because Prof would have gone over this morning, but essentially we spoke to the women antenatally at birth, 9 to 12 months postpartum, and 18 to 22 months postpartum. So the first section, the variables are the mother's reports of health during pregnancy, as well as their self-reported health status at 9 and 18 months postpartum. So the most commonly, just to say that we gave them a long list and asked, did you experience these things during pregnancy? And the most commonly reported things are, I guess people would call common side effects of pregnancy: frequent urination, swelling, edema, back pain, and abdominal pain. However, 14% of the mothers interviewed antenatally also reported that they had hypertension, protein in urine, and diabetes, 2.7%, and 1% had seizures, reported seizures. Overall, during pregnancy, around 20% of our mothers reported that they had at least one admission during pregnancy, not including the admission for labor and delivery. 80% of those who were admitted reported that they had been admitted once, with 19% being admitted between 2 to 4 times. In general, there were no significant differences between those who were admitted and those who were not by age, SES, and education. However, for mothers who had multiple admissions, they were significantly older than mothers who had a single admission. The main reasons for admission were hypertension, abdominal pain, excessive nausea, vomiting, and vaginal bleeding. So, chronic illnesses. When asked at 9 to 12 months postnatal, 22.8% at 9 months and 20.7% at 18 months reported that they had some sort of chronic illness. And the most frequently reported chronic illness was hypertension. And as you can see, the proportions, maybe you can't see so well, but the proportions are basically the same at 9 and 12 months, followed by asthma and diabetes. And then we had a smaller proportion that were admitted that had sickle cell and reported having seizures. Admissions at 9 and 18 months postnatal. So essentially we had, at 9 months, 5.4% of our participants reported that they had been admitted, and 3.5% had an admission at between 9 and 18 months. So these are, so it says since the birth of the baby at 9 months, and then since the baby turned 1, were you admitted? Those are the parameters, right? So at 9 and 18 months postnatal, there were no significant differences in the ages of the mothers who were admitted. Neither were any significant differences in terms of SES or education. So as we see still, the reason for admission between birth and 12 months was some hypertensive-related admission, infection related to C-sections, surgery for some sort of appendix or gallstone surgery, some sort of trauma, vaginal bleeding. At 18 to 22 months, the numbers have fallen, but still the number one reason for admission was hypertension. So, to summarize, based on the data, I kind of went through faster than I thought I was going to. Older and less educated and poorer mothers sometimes reported more issues with their health in the antenatal and postnatal period. There is some indication that hypertension as a pre-existing condition and then complication of pregnancy continues to be a major problem in maternal health. And there is some indication that we should try to follow mothers at least 1 year post-delivery to ensure that we mitigate against some of these complications. So the limitations of this study, the primary limitation of any kind of survey is that we're relying on maternal self-report. We're unable to verify in medical records the actual incidence as well as the actual severity of the condition. And also people's ability to remember and to know why they were admitted, because one of the gaps in the data is that people are admitted, but they're not necessarily able to tell you why. And in Jamaica, we don't know diagnosis, so that's one of the things. And also, as I noted at the beginning, I think they're still working on how to classify non-severe maternal morbidity. So because this study came up as part of the work of that working group, I'm not sure if they're finished yet. And thank you.
Wow. I think she's trying to get us back on track with time, right? Thank you very much, Jody. Okay, so we move even more smoothly now. And I'm going to now ask Dr. I'm not going to try and pronounce that first name, okay? Dr. Bernard, who is a psychiatrist in the southern region of Jamaica. And she is going to come and talk to us today about a paper that I think is published, yes? And that is Antenatal Depressive Symptoms in Jamaica Associated with the Limited Perceived Partner and Other Social Support. I'm looking forward to this. Please help me to welcome her, ladies and gentlemen.
Hello, good afternoon, everyone. My name is actually Omotayo Bernard. And thank you, J Kids, for having me present today. I will be looking at antenatal depressive symptoms in Jamaica associated with limited partner, perceived partner, and other social support. And this was essentially a cross-sectional study and was published in March of this year by PLOS, which is the Public Library of Science. The authors are, as you see, myself, Professor Roger Gibson, Professor McCobbins from the Department of Community Health and Psychiatry, Miss Jody Reece, Dr. Charlene Cordesai, Miss Pellington, and Professor Maureen Samms-Vaughan. So the aim of this study essentially was to determine the prevalence of factors associated with antenatal depressive symptoms among Jamaican women, and to inform policy and build interventions that could improve their management and reduce the negative consequences of these risk factors. There were several objectives, so I'm just going to summarize. We looked at some of the socio-demographic characteristics of the participants. We explored their obstetrics parameters. We did frequency and severity of depressive symptoms, and we also explored the association with these factors and the depressive symptoms. We also looked at social support factors, and again, we explored if there was any correlation between the social support factors and depressive symptoms in these antenatal mothers. We looked at partner-related issues. We looked at the prevalence of perceived partner infidelity. We looked at prevalence of mothers having multiple childbearing unions, and we looked at whether or not having a child, numerous children for her current partner also contributed to any significant depressive symptoms versus a mother who had multiple childbearing unions. Why was this study important? What we realized is that 1/5 to 1/3 of women in developing countries will have some mental health concerns during their childbearing period. Antenatal depression is also associated with adverse maternal and infant well-being, and it's less so studied in Jamaica than, per se, postpartum depression. We have local data to suggest that mothers are depressed within pregnancy. Dr. Pottinger, along with other researchers, actually found that 25% of women in a study done had probable features of depression. Another locally done study with 78 mothers from an urban sample found that over 50% of these mothers had some depressive symptoms. What are some of the contributing factors in low and middle income countries? By mere fact of them being low and middle income, mothers are noted to be more predisposed to having depressive symptoms. And some of the other factors highlighted, which is similar in our setting, includes mothers having inadequate income, financial difficulties, young maternal age, intimate partner violence, as was mentioned before. Mothers with a history of depression were likely to have more depressive symptoms in their pregnancy. And inadequate partner support is also a very significant contributing factor. What we note in Jamaica is that our family structure could be contributing to some of these depressive symptoms. What we commonly see here is that the partners establish visiting relationships, which, as Professor Samms-Vaughan would have mentioned, that tends to be one of the most unstable union. And then you have separation with single parenting, and this is thought to be one of the associated risk factors as well. The family structure in the Caribbean tends to be a bit different, with mothers having multiple childbearing union, and we also explored if this could have been contributing to these depressive symptoms. Other partner-related factor is the issue of partner infidelity, and as was mentioned before, by the age of, I think it was mentioned, 4 years, most of the unions would have been separated, and what a locally done study had identified was that Jamaican men tend to consider polygamy as a normal routine behavior. And I know I'm stirring the looks and I'm seeing the smiles, and persons are saying true. Intimate partner violence also contributes significantly to depression in the antenatal mothers. And of course, we explored that obstetric factors do contribute, especially multiparity and comorbidities within pregnancy. We looked at what are some of the consequences of antenatal depression. Depressed mothers are less likely to access antenatal care. They're at more risk for substance use. They are less likely to be astute about their nutritional needs within the pregnancy. And antenatal depressive symptoms, of course, increase the risk for postpartum depression. There is also an issue with inadequate fetal nutrition, increased risk for preterm delivery or low birth weights, and small for gestational age neonates. And it's also associated with psychological consequences, which is poor maternal and infant bonding, especially noted at 8 weeks. In terms of long-term consequences, we have noticed that children born to mothers with depression during pregnancy may have behavioral difficulties, and anxiety disorders have been noted, even up to 18 years of age. And of course, this is a healthcare burden because mothers would have had impaired function, loss of maternal role, and long-term consequences also persist. So the method of this study, essentially, it was a secondary analysis of data collected from Jamaica, the Jamaica Kids Birth Cohort. And Professor and others have gone through that method for that study. For our study, the inclusion criteria was that we gathered data for mothers responding to the mental health screening questionnaire, and that amounted to 47% of the mothers recruited in the study. We, however, used our sample worked out to be 3,517 mothers, because those were the mothers who had essentially responded to the questionnaire in completion. Again, the instruments would have been similar to what was described, the 3 questionnaires: my expectation, my life, and my health. And the most important part of the questionnaire that we used to assess depression was the Edinburgh Postnatal Depressive Scale. And we used categories of 0 to 9 that were considered to, mothers with that score were considered to have a low likelihood of depression. 10 to 12, mothers were considered to have a moderate likelihood of depression, and 13, a high likelihood of depression. We looked at socio-demographic factors and factors surrounding social support. We looked at other variables surrounding partners, as I have mentioned before, the number of children for current partner, the number of childbearing union. We did statistical analysis, including mean and interquartile range for the continuous variables, and we did frequency and percentages for the categorical variable. In the end, we used a multivariate logistic regression analysis for all the significant variables that we found. In terms of the results, we found that 1 in 5 mothers were assessed as having a high likelihood for antenatal depression. We also found that 14.4 mothers had a moderate likelihood of depression. This is just depicting what we had found. Some of the socio-demographic findings were that most mothers, the median score was at 28 weeks in terms of gestational age, and median gravidity was 2. There was no significant association between the EPDS score and maternal age, income, gravidity, previous adverse pregnancy outcome, number of previous childbearing unions, and number of children for current partners. Sorry. And that just shows the p-value and what I just described above. What we found was that there was association between the EPDS score and lower levels of perceived partner social support, exposure to abuse, and partner infidelity was also noticed to be one of the contributing factors to depressive symptoms. Again, that shows what I had just highlighted. Our regression analysis showed that women who received little emotional support were more likely to have high scores. Women who had little help with chores, women who had reported that their partners weren't too keen on their pregnancy initially, also had higher EPDS scores. We found that women who expressed that their partners were unfaithful within the last year, or women who were exposed to violence or having financial difficulties were also more likely to have depressive symptoms. So what we found was that 1 in 5 antenatal women had a high likelihood of depression, and this is similar to the local studies that I had highlighted before. And this provides a fair enough amount of evidence to suggest that our mothers are having antenatal depressive symptoms in their pregnancy. Protective factors against antenatal depression included the perception of a support system. And mothers who generally said they had support were found to have lower scores. There were also partner-related issues that contributed, such as partner infidelity, exposure to violence, and rejection of the pregnancy in the beginning of the pregnancy also contributed to depression. So we advocate that strategies should be aimed to strengthen a mother's support during pregnancy, and, for example, employing very simple methods such as a positive partner response to the pregnancy, For example, encouraging participation in support groups and encouraging other family members to get involved in the pregnancy. We found that exposure to violence also significantly contributed. However, for this data, we didn't have specific information at the time about intimate partner violence, so that was inferred during the research. Financial difficulty also significantly contributed to antenatal depressive symptoms. And what we found out was that even high-income mothers reported financial difficulties. So it therefore meant that financial difficulty was a perception of the mother and probably had contribution from other expenses, for example, that the mother would have been facing. So income wasn't a direct indicator of financial difficulty. So there were several possible factors interplaying with antenatal depression in this cohort. In terms of our limitation, it was a secondary analysis, and so therefore the original objectives within the questionnaires weren't designed specifically for our research. It was a cross-sectional nature, and so therefore the depressive symptoms could only be assessed at a particular point in time. The EPDS has not been validated in Jamaica, but was validated elsewhere and has been used in the antenatal population. And of course, there was an issue, may have been issues of response bias, especially to the questions surrounding intimate partner violence and other personal information. There was a concern about missing data affecting the accuracy of the results. So in conclusion, a substantial proportion of Jamaican antenatal mothers have significant depressive symptoms. And there are several factors associated, including financial difficulty, partner infidelity, and exposure to violence. There was also an association between perceived social support, partner support, and it implies that these resources should be enhanced during pregnancy. And I think that is it. Thank you.
Thank you very much, Dr. Bernard. That was very clear and concise for all of us. Okay, so we're moving on to the last person. I'm just going to pause and remind those of you who need CME credits that they will be available at the end of the day, 3.5 for today, and then 2.5 for tomorrow, and you can collect it outside at the front. Okay, so Mr. Bateman is coming to us next. He's going to be presenting on behalf of his group on patterns and predictors of depressive symptoms among Jamaican fathers of newborns. Mr. Bateman is a member of that very long name department, and he's an associate clinical psychologist about to head off to do his PhD in kinesiology, I think it is. Please help me to welcome Andre.
All right, thanks, Abby. I hope everybody is hearing me clearly. All right, so I'll be looking at the fathers now. So the patterns and predictors of depressive symptoms among Jamaican fathers of newborns. So previous studies have suggested that approximately 10% of fathers actually have pre- or postnatal depression. However, these rates vary widely. What happened? Did something happen? Oh, okay. Yes, so the rates actually vary widely from 1 to 25%. However, what was found is that they vary because different measures are actually used to measure the depressive symptoms, and there are different time points for assessing depression, and of course the population and contextual factors. As is usually the case, most of the research that we have available has been done in the cultural West. By this, we're referring to the countries such as the UK, the US, and Australia. However, other studies have been done in China, Japan, and Brazil, where an 11% prevalence was found in Chinese fathers, 12% in Brazilian fathers. However, these studies had small sample sizes of only a few hundred participants, and they were usually convenient samples. So what has been found as predictors of paternal depression in these previous studies are, one, the father's previous history of depression, occurrences of maternal depression, so the depression symptoms in the partner, employment status, along with other socio-economic factors, relationship dynamics, particularly the quality and status of the relationship, and variations in social support, and also discrepancies between the paternal expectations and the reality. So in the present study, we employed the Edinburgh postnatal depression scale, as was mentioned before, and the predictors that we considered were relationship status and quality, social support, age, and paternal attitudes. And the EPDS measures depressive symptoms and not necessarily depression, as was explained earlier. And it is currently the most widely used measure of parental depression, and it has various cutoffs. For our study, we used a cutoff of 10, which was also explained earlier. And bringing it back now to the cultural context, in Jamaica, there's a high prevalence of matrifocal household systems, and fluid partnerships are also very common. Visiting relationships, as was also mentioned before, is very common, and most children in Jamaica tend to be born into visiting or common law relationships. And some of the reasons for this may be historic, based on slavery, and also contemporary, based on situations such as employment status, poverty, and economic factors. And it is generally accepted in Jamaica that the major expectation of fathers in our context is to provide economically and financially. So of course, the data that we use for our analysis came from the JA Kids National Cohort Study, which took place between July and September 2011. And the sample, the sample, as you know, would represent approximately 86% of all the births that took place during that period. And the importance of our study was to increase the basic knowledge of paternal attitudes, relationship dynamics, and the mental health of fathers, because very little is known about these factors as they relate to fathers. Much more is known about mothers, and particularly fathers in developing countries. So based on this, we decided to test the hypothesis that men's depressive symptoms will be predicted by his socioeconomic status, age, relationship status, and quality, wider social support from kin and friends, and their attitudes towards having a new child. And I'll say a little bit more about each of those. So just over 3,000 fathers of newborn children were sampled, and the data was gathered using structured interviews at hospitals and birth centers across the island. And the socio-demographic, and we collected socio-demographic information such as age and living arrangement, wealth. For wealth, we used an index of material items, such as having a washing machine, education, relationship status. We also measured relationship quality using an index of 17 items, one of which was, did you enjoy your baby mother's company? We measured wider social support. We also measured father's attitude towards a partner's pregnancy, and this was particularly significant because we measured this based on when the father found out that the mother was pregnant and just after the birth of the child. So as I said before, just over 3,000 fathers participated. The average age was just less than 31 years old. Notably, for education level, just 12% reported having completed tertiary education. The most common occupation was farming. 12% reported having 8 to 10 of the 10 material items that we asked them about. And in terms of relationship status, the majority were in common law relationships with the mother. Okay, in terms of relationship quality, with scores that range from 17 at its lowest to 68 at its highest, only 4% of fathers had scores of over 40. And in terms of social support, we found that wider social support was relatively high. Notably, 78% reported belonging to being a part of a close circle of friends. So in terms of paternal attitudes, upon hearing the news of the pregnancy, 70% of the men reported being happy, only 70%. And at the time of the child's birth, this number increased to 92% of the men reporting being happy, which is somewhat interesting. In terms of depressive symptoms now, using the EPDS, as I said before, the average score was found to be 3.45, which is not very high. However, as it relates to possible depression, what we found was that there was a prevalence of 9.1% of Jamaican fathers who were at or above this level. Okay, so in terms of our statistical analyses, we found that relationship status and educational attainment were not related to the father's depressive symptoms. However, age, relationship quality, and material wealth negatively predicted depressive symptoms. So the higher the age, the lower the symptoms. The better the quality, the lower the symptoms. The higher the material wealth, the lower the symptoms. And each of these predictors, when incorporated into a multivariate analysis, remained significant. However, relationship quality was most significant in predicting depressive symptoms. And this table pretty much just gives the numbers for what I just explained. So moving on to the discussion. So our study was a large systematically recruited used a large systematically recruited sample to assess the paternal depressive symptoms and possible predictors. We are aware, however, that the sample that we use may be more representative of the more invested fathers, because they're the ones who are most likely to show up and actually complete the data collection. The limitations to our studies were, of course, that it was a self-report. We used self-report responses, and to measure depression particularly, it was cross-sectional, and it captures time at birth only, So as I said before, the prevalence of possible paternal depression was 9.1%, which was comparable to the 10% found as an average in most studies. Relationship quality but not status predicted depressive symptoms, which differs from what we have seen in previous studies and populations, suggesting that there is some sort of cultural significance where this is concerned. In terms of wider social support, we found that it was associated with lower depressive symptoms. So the higher the social support, the lower the depressive symptoms. And this, of course, is supported by extensive research, which suggests that social support does buffer the impact of mental health concerns. In terms of paternal attitudes, what we noticed was that there was a greater ambivalence or negative views associated with higher depressive symptoms. And of course, the findings of our study is of relevance to clinicians, counselors, and whoever would intervene with fathers at around the time of pregnancy and birth. And that's about it. And these are my acknowledgements. Special thanks to Peter, who helped significantly in preparing this presentation. All right, thank you.
Thank you, Andre. So I'm going to invite Mr. Bateman to not sit yet, as Dr. Bernard, Dr. O, Ms. Reece, and I think Prof. Samms is currently doing a live broadcast. So any questions you have on her presentation, kindly direct them to Jody Reece. All righty. So I think we've had a very rich panel of presenters. We went from the broad perspective of the 5 years, then we went down to the nitty-gritty of how the babies come out and how the pregnancies end. We looked at the mothers, illnesses, both physical as well as their depressive symptoms. And then happily, we also looked at the males, because oftentimes we don't get to hear about the men. So it was good to hear about the men. So we're going to have to be tight again in controlling questions. So I'm going to ask you to raise your hands, and I think there should be a mic somewhere for our panelists. I'm sure IT will soon get that for us. Okay, great. So I'm going to ask you to raise your hands. There's a gentleman straight up who has been very bang on. We have a roving mic. Can one run up? We probably only need one down here, and then two can rove. Can I ask some of the, I don't know what you call them, volunteers or so. Are you a volunteer? That's what you all call it. If you can rove with the mic, one on either side maybe. That gentleman is the person asking the first question. Right there, coming down the steps. We have made him walk far. Press the little button.
Testing. All right. Good day, everybody. I have a question for Prof. Vaughan, one, and a question for Mr. Bateman. All right. So
maybe start with Mr. Bateman.
Yeah, I was going to say if I should just start with Mr. Bateman. All right. So I noted that in your study you were saying that a number of the men you studied were farmers. I would be interested, I don't know if you had found out or you intend to find out if many of them were a part of the farm working program or if they participated in the farm working program. I think that would be a kind of an interesting, because if the socioeconomic data suggests that people who are farmers in Jamaica many of them are the lowest socioeconomic cohort, it would be good to see if the ones who were interested in fathering and turning up, as you said, were they farmers that were not in the farmer program and those who would have been, who felt probably more financially confident and more stable?
All right, yeah, I think that's actually a very good question. I was a little bit surprised to see that farmers had the highest percentage. But your suggestion does make sense. I must admit I did not think of it before, because it would speak to wealth, as you also implied, which was one of the major predictors. So it is possible, I would think, that some of these may be fathers who did the farm work thing. However, we do not know, and I do not know if the data will allow us, Jody says no, to get that sort of information. But that is actually some good thinking. Yeah.
All right. So instead of asking the question Samms-Vaughan, I'll just do my final and second question to Mr. Bateman also. It would be good, I don't know if you also did try it, you said you put the data in different matrices to study, to analyze it. I don't know if one of the matrices that you put it in were to look at, especially in relationship to the men who were farmers, like which parishes did they come from? Because there are some parishes where farming is much more thriving than in other parishes, or particular regions or counties. So that would be interesting also. Yeah,
I do agree with you that there is some value into further investigating, this farming thing coming up as one of the major employment of the fathers that we sampled. And I could make suggestions that we look into it further. That's a good suggestion. Thanks.
Thank you.
Thank you. Any other questions? Thank you. Yes, I have somebody right here. Maybe come to the front and then scoot it up. Wow. You're on the hot seat, Mr. Bateman.
No, I was wondering, in terms of measuring for depression in men, how are you able to distinguish between whether or not the symptoms existed before antenatal period, or I'm trying to decipher how you were able to connect the antenatal period to the depression symptoms, because it could have existed pre that period.
Well, the scale is actually designed to measure depressive symptoms around that period, so the items will be worded in that way. Yeah, that's...
But the symptoms could, I know it's a standardized scale, but the symptoms could still have existed before that. I don't know if in the data collection any kind of...
a limitation.
It is a limitation.
Yeah, it is, yes, there is, that does make sense, but remember also that one of the things that we found in previous studies was that a previous history of depression was able to usually predicted paternal depression at the around that period as well. So it seemed as if in other studies they were able to separate the two. So previous history versus postnatal.
Okay, thanks.
Any other questions? Yes, please go ahead. Row 4. And then Prof. Iman.
This is for Dr. Bernard. Antenatal depression is associated with adverse maternal and infant well-being, and you made mention of the postnatal depression screening tool. Is there a tool for the antenatal period?
There is not a specific tool for the antenatal period, but the EPDS has been validated in the antenatal period in several studies worldwide, just not in our setting. So it is a validated screen in the antenatal period.
So how do the midwives get access to all of this tool to use it then? Is it that for the midwives to use, or is it for the doctors to use?
Well, it is widely available, and it is an accepted screening tool that is, for example, used in South Australia, and a lot of those studies, they essentially incorporate it in the antenatal care visits at different points in the visit. So it's a widely available tool, and it's actually available online.
Oh.
So it's an available tool.
Being used by all
it is a screening tool.
Thanks.
Right, so just to underscore, if I can take chair's privilege, if the midwives are going to use it, then it would be really to determine if you need to refer on as well. Well, really, even if it's the obstetrician that's screening, they would refer on as well. Any other questions? I'm going to take chairs. Oh, Prof. Iman, yes.
Thanks so much. I'd like to ask Dr. O about the implications of the neonatal mortality, and in particular about the whole problem about dealing with the extremely low birth weight very preterm. Because you implied really that to move forward, resources should be targeted at those over 1,000 grams. But that's a difficult thing to implement, to say to people, don't resuscitate, don't transfer babies that are less than 1,000 grams.
All right. So we're not saying don't resuscitate or don't transfer. What we're trying to say is that given the resources that we have, given the limitations of what we have, if we were to reduce the mortality of those over 1,000 grams by 50% over the next couple of years, we can actually achieve less than 10 per 1,000 in terms of where we, rather than being excessively, because sometimes we get excessively aggressive for babies less than 500 or 500 to 750, and even some of the data I did not show here. At the University of the West Indies, we still have problems with those. While our own mortality is more related to those less than 1,000, we are not seeing this, what was one of the surprising things with our study was that we were surprised that the mortality was actually higher in those over 1,000 grams, because that's not what is happening at the university. 75% of our deaths was occurring in babies less than 1,000 grams, which is totally in terms of the weight. So I think the policy implication really is going forward, if each unit where babies are delivered should actually look at their data, see where the problem lies, whether they're having problems with those over 1,000 grams in terms of mortality, which may be similar to what we're having, or less than 1,000 grams in terms of where the bulk of the mortality, and then focus on actually reducing mortality for the easiest set, thinking about the cost of care and the benefit of intervention.
Thanks, Dr. O. I know Dr. Ashley seemed as if she was about to hop out of her chair. And after that, we'll take one last burning question if we have any.
Thank you. Just following up what Dr. O said, the problem of obstetrics, because we still are having too many emergency C-sections. The figure looks a bit less than it was in the 86 study, but emergency C-sections are still associated with high mortality. And therefore, that's where we need to see, why are we having so many emergency sections? The management of labor and delivery is critical. So I think we need to go back to basics. And a lot of that relates to the monitoring during labor. It was in the past, and it looks as if it's still there.
Thanks, Dr. Ashley. Okay, so I think in interest of time, we are going to wrap up this panel, and I'm going to thank all of our speakers for doing a really excellent job. Thank you. And I'm going to hand over my task to the next person, who is Sydney Shakespeare. Is the moderator? No? Heather Gallimore is... Oh, there we go. Yes, Heather. Here we go. Thank you.
Thank you. Thank you, thank you. Esteemed guests, ladies and gentlemen, good afternoon. Okay, before we get started, I would like everybody who has the mobility to please just stand up, because I did notice some eyes shutting down for a moment. So please, stand up. We don't have time to play Simon Says, but do the stretching. There we go. And I have heard from reflexologists that if you rub your earlobes, it helps to keep you awake, especially when driving. Okay, my name is Heather Gallimore, and I am your moderator for this session. And I want to tell you the one thing I know for certain about parenting, and that is that having a child makes you no more of a parent than having a piano makes you a pianist, right? So we are going to hear from our experts today. We know this is the most challenging job that any of us could have, and we know we need greater support and recognition in our society for parents. And I have been asked to speed this up, so I am pleased to welcome 4 accomplished researchers who have looked at parenting supports from various or different perspectives and are here to share briefly on their interesting and relevant work, which is informing the design of more effective programs, interventions, and promising practice in our context. Our first speaker, Ms. Cynthia Hobbs, will speak on information-seeking behavior in Jamaican parents. This is not about how they use Google. It's about reaching the unreached, developing culturally appropriate group parenting programs that appeal to parents of all walks of life. So, ladies and gentlemen, please give us your full attention and welcome Ms. Hobbs.
What do I do to make the... Oh, just... Right, got it.
Good afternoon. I just want to say that I have been privileged to support this study from its inception, and I have to say that what this small team from JA Kids has managed to achieve is nothing short of awesome. So big up to them. So research shows that parenting plays a central role in children's growth, health, development, and well-being, and the development of children's social and cognitive skills is influenced by the quality of interactions that they have with their caregivers. And we have seen from Jamaica's first cohort study that quality interactions during the early years have long-lasting effects on people's confidence, autonomy, personal well-being, job opportunities, and life choices. There's evidence that structured programs to promote positive parenting reduce problems for children, especially young children, and contribute to healthy development. And Professor Samms-Vaughan did a study in 2005 that showed that Jamaican parents are experiencing high levels of stress. But parenting information can help to reduce that stress. However, what we've seen is that parents from lower socioeconomic families and parents living in rural areas have less access to quality parenting information. So we've looked at the data from this study and hope that the results of it will inform parenting policies and decisions for the National Parenting Support Commission and other groups working on parenting programs. So who participated in the study? There was an initial study carried out in 2011 and 12 using a subset of the cohort study. 251 women participated. But then later data was collected from the larger group, so we now have data from an additional 4,589 women, and I'm going to share the data from that larger group. Both studies showed very similar results, and the sample was reasonably representative. 35% of women in the larger data set were first-time mothers. So the data was collected through questionnaires. Prof mentioned them. One was the looking at parenting data, a questionnaire called My Expectations of My Pregnancy, My Parenting, and My Partner. And then the other looked at demographic and socioeconomic data. The average age among the participants was 25 years old. The largest group was 20. And as Prof mentioned, to determine socioeconomic status, women were asked about possessions, ranging from inexpensive items like a radio or a fan to expensive items like a car or an air conditioner. You see in the bottom graph that 25% were in the lowest or poorest group with owning as many as just one item, and only 7% were in the wealthiest group owning as many as 21 items. We also looked at previous parenting experience, and 30% of the women said that they had no parenting experience whatsoever. For those 7 out of 10 who had previous experience, the orange group here, then we look down at the other one, the majority of that experience was obtained through interactions with their own children, and then a much smaller group with younger brothers and sisters, other child relatives, or partners' children. Approximately 66% reported they had experience with children under the age of 12, and interestingly, over 60% reported that they had experience with one gender or the other, but both genders being equally represented. We looked at their behavior for seeking out information, and less than half of the women, under 40%, said that they sought information to prepare for parenting prior to pregnancy. 40% did not seek out parenting information because they didn't think that it was necessary. Interestingly, those who were most likely to seek out information already had children. I guess once we have them, we know how little we know. 41% said they knew a lot about parenting prior to pregnancy, and this increased to nearly 65% because they consulted different sources. Once women were pregnant, the majority did seek out additional information, and 76% of them were most likely to go to a health professional. We think that they were health professionals were most likely identified because they are seen as respected and knowledgeable in their communities, and the pregnant women had contact with them during antenatal visits. Other important sources of information were their own mothers, female friends, books and magazines, and other female relatives. A much smaller number looked to television, and a much smaller number looked to their partners for information. And only 12.1% reported attending parenting classes. The majority of women felt strongly that they should provide stimulation to babies through smiling, hugging, talking to them, or reading to them. However, there was still a significant minority who do not report that stimulation is important. For example, nearly 1/10 thought that hugging babies or reading to them was a waste of time. And nearly 20%, or 1/5, thought that babies don't need anyone talking to them because they don't understand what they're saying. Over half the women reported that babies needed to adapt to their lifestyle and schedule, and 8 out of 10 said that the baby needed to develop regular patterns of sleeping and feeding as quickly as possible. While women did report that their own enjoyable activities would be restricted, they also seemed to look forward to the new experiences that would come with having a baby. And in terms of lifestyle, women reported that they were careful about almost always or often resting, 78%. They were careful about what they did and where they went, over 80%. About attending antenatal care regularly, over 90%. And about eating only healthy foods. But 66% reported that they were less likely to exercise, possibly because they were afraid to harm the babies. So how can we use this information to guide delivery of parenting programs in Jamaica? We have 10 quick recommendations. First of all, the data shows large gaps in delivery of parenting information, and so there's room to develop additional sources, including parenting support and education programs. Secondly, because the health professional was identified as the most important and highest quality source of parenting information, it would be important to assess the training that they are providing, as well as their perception of whether they could provide more parenting information. Thirdly, because the pregnant women only have a few visits during the antenatal stage, it would be important to look at whether it's possible to extend support to well-child clinics, since they see health professionals 5 to 6 times during the first year of the baby's life for immunizations and checkups. Fourth, there were infrequent reports of obtaining information from parenting classes, but that might just suggest a lack of access to those classes. So one possibility would be to offer the classes at the health centers and well-child clinics, where the mothers reported that they are going and respect the professionals that are working there. It also helps to reduce a bit of the burden on the health professionals, because they could participate but might not have to be the sole providers of that information. And since this study was done a few years ago, I can happily report that the Ministry of Health is in the process of introducing the Reach Up and Learn program to well-child clinics. So that's one thing that has come, one policy that is coming out of the research that's been done. Fifth, because grandmothers are often caregivers, they should be included in the parenting programs. Sixth, because there was a large percentage of first-time mothers that reported that they were less likely to seek information and didn't really know much about parenting, it would be important to try to make the programs, design the programs in such a way that they would attract first-time mothers. But since there were also a large percentage that already had children, they would also need to consider those women's prior experience and existing challenges. Seventh, because the partners were infrequently identified as a source of information, but we all know that they probably actually know something about parenting, it would be important to include programs that would attract the partners, encourage the father's self-esteem, and encourage them to support the mothers. Eighth, it would be important to have parenting programs focus on the importance of exercise and healthy living, and how to respond to babies, and how to stimulate them through talking to them, reading to them, smiling, hugging them, etc. Ninth, it would be good if the programs talked about the impact of parenting on previous lifestyles, so there were realistic expectations about mothers' lifestyle changes. And finally, when asked whether the mothers expectant mothers preferred to have a boy or a girl, there was a strong preference for girls. And UNICEF did a household survey study in 2009 that suggested that there are differences in care and provision by gender in the first few years of life. So it would be interesting to investigate those gender preferences. And that is it. Thank you very much.
Thank you, Ms. Hobbs. I apologize. I should have introduced you properly in my haste. Ms. Hobbs is... Thank you. She warned me about this to get it right. She is the lead education specialist at the Inter-American Development Bank in Panama. And she is also the past IDB team leader for the JA Kids study, which leads us into our next presenter, who is Dr. Charlene Kaur-Desai, an instrumental behind-the-scenes person here, who is also the JA Kids Study Director. And she will speak with us this afternoon on the supports for families in neonatal intensive care units in Jamaican hospitals. This study looks at the extent of support parents receive at Jamaican neonatal clinics during the extremely difficult time for parents of newborns. Dr. Kaur, help me thank her. I don't know if I can do as well as Cynthia with time. I'm a little tired, so everybody just please bear with me. Okay, I want to thank Prof. Eamon because he gave me a brilliant way to start my presentation for those of you who were here last night. I have some conflicts and confessions to make before I start this presentation, because I myself am someone who had children actually in a NICU. And so this is a topic very close to my heart, and I just wanted to make that clear, that this is from my own experience, and this is one of the reasons why we had this sub-study in JA Kids. Okay. So just very basically, what is a NICU, or a neonatal intensive care unit, or sometimes called a special care nursery? This is a place where we care for the babies who are born early, or who have problems during delivery, or who develop problems and require a high level of care. Although all NICUs care for babies who need extra help, different NICUs or different special care nurseries can provide different levels of care, right? What can we expect from the neonatal environment? Well, as you can well imagine, the reason why a child would be admitted to a NICU, usually and Dr. O spoke about some of these things. It could include prematurity, sepsis, and respiratory difficulty, along with a host of other issues. And I don't have to tell you that this can be a very stressful environment for both the staff and the parents who are there. And for parents especially, it can be a very frightening experience, because you have an expectation of a regular delivery, a delivery on time, and then everything changes. You've made some preparations to, to bring your child home, and things don't necessarily go according to the plan. And if you're like me, you like the plan, right? And when the plan doesn't happen, it can send you into an extra tailspin, as well as having a child who is ill. So for parents of babies who are admitted to the NICU, they're often facing difficult situations which contrast with conventional postnatal care and transition to parenthood.
stress levels very high, uncertainty about the baby in that moment, but also the longer term concerns that may result from their illness, and encounter challenges to the development of their parenting roles, right? As I mentioned, you have a certain expectation, and now you have to orient yourself to something a little different. Okay, so it's clear that we want to offer support to families, parents who may have a child who has to go to the NICU. So what is family support? At the very heart of it, it's enabling parents to care for, take responsibility for, and gain knowledge about their sick and preterm infant. So it's about empowering parents in this situation. Now, there are several different types of family support, but we want to make it clear that supporting families in the NICU doesn't necessarily have to start in the NICU. So if you know you have a high-risk pregnancy, for example, maybe we can start to talk about what this might mean. And it does happen in our context. So for mothers who may be admitted in the hospital, there might be start the discussions that, you know, there is a possibility that you might deliver early, there's a possibility that your child or your child will go to intensive care, and these are some of the things you can expect. But in other places, they actually do maybe tours of the NICU and so forth for persons who are, as I said, high risk. But a lot of the support comes, the bulk of the support comes when you're in the actual, when you're actually admitted. And some of the types of support that take place during this time, and as I mentioned before, and I want to make it clear, I know that it's also very stressful for the staff who are working in this high pressure situation, right? And things change very rapidly, but it is also important for parents to get clear, concise, and in many cases, written information. I know for me, there were times where doctors and nurses were saying things, and I can assure you that I wasn't really with them in the moment. And then more practical things. So for parents who may not have a lot of resources, there's opportunities, and lots of hospitals have social workers, for example. And so who might need support in terms of even just transportation costs to come and visit your child in the NICU, which clearly would be an important thing for parents. Helping the staff to be aware of the profound effects of separation. So again, one of the things is that you could have, for example, a way to ease parents' anxiety to know that there's always a way to get through, not just calling the hospital switchboard and then hoping that you get in touch with the NICU. So having dedicated phone lines, for example, having parent rooms where parents want to overnight or they just need a break, there's a comfortable place for them to go and relax, because they don't want to go too far, especially if your child is experiencing distress or something. You know, you don't want to go home, for example. You want to be somewhere that if anything happens, you can quickly get back there. And parents do, this is one of the main issues, the feeling of separation. Supporting families during the discharge, doing discharge preparation. So there's also the issue of transition to home support. So it's scary too, you know, not just being in the NICU, but now you have to go home and you have to take a 3-pound baby with you and you're, again, not accustomed to this or haven't had an experience with this. We have to help and support families in terms of that transition. And although discharge planning starts at admission, it should start at admission, preparing persons. It does kick up at that time when you're about to go home. And then finally, supporting the family of the dying infant, because as Dr. O said, outcomes for children in the NICU, you know, children do die, especially if they're under a certain weight or they have other issues and complications. And so one of the ways that we can support parents and families is to prepare them for what's going to happen. Okay, considerations in a family-centered approach. So we're trying to make a move from active versus passive. So, sorry, the other way, from passive to active. So including families in decisions, including families in their infants' care. Also just remembering that parents are not just one group, and you need to look closely at cultural and social backgrounds of parents to provide adequate support to them. And also to include other members of the family, especially siblings who, again, might have had their own expectations or might feel marginalized in this situation. Okay, in terms of the Jamaican context, we do have some intensive care units in different regions. Obviously, Bustamante being one of the main places that the very seriously ill children will go to. But in my discussions with the Ministry of Health, there is some kind of special care offered at several places now, right? And in the training manuals for the Ministry of Health, they do have specific information that they give to the people that they're training in terms of how to support or how we handle parents in neonatal intensive care units. It's a start, but I think there's a lot more that we all know that we can do, even something that doesn't cost a lot of money, right? Because we have limited resources. So with all of this, this is what we wanted to do. We wanted to look at parent support, examine what was available, and how effective what we do have is for parents. And for today, the only thing I'm really going to talk about is the objective where we want to just identify the needs of parents who have infants in neonatal care units. Okay, so we wanted to know what are the needs of parents who have infants there, what supports currently exist, and what do parents say are the most helpful. Okay. So during the 9 to 12-month telephone contact, at a certain point, so we didn't capture everybody who participated in that particular contact, but for a short period of time, if we asked parents if they had a child who was admitted to a special care nursery or the NICU, and if they were, then we asked them an additional set of questions related to the supports that they got. And the questions were really divided into 3 categories. So we asked about the level of satisfaction, so how the doctors treated your child, how the nurses treated your child, but also how you felt that you were cared for in that setting. We asked about the information that parents got, and the information, we broke it down into, did you get information about your illness, so what's happening to your child? Did you get that information, was it easy to understand, and was it given in a timely fashion? And if you even wanted information on the child's illness in this situation. Then we looked at the treatment, so what kind of medications, what kind of tests. Again, was the information given to you? Was it easy to understand? Was it done in a timely fashion? And did you actually want this information? And finally, about the care of the child, because in all of this, we have to remember that, yes, these are newborns, and so the regular things of feeding and bathing and changing diapers are also a part of what's happening in the NICU. And then we asked about support, and we asked about supports in the hospital and supports outside of the hospital. So did you get any information? Did anybody say to you, maybe in the transition to home, or if your child had died, did you get any information about further support or support in that moment? So there were 427 families that participated in this sub-study. It was mostly mothers that we interviewed. I mean, when we called the primary caregivers, normally the mother. So this is some of the results in terms of the satisfaction with treatment by staff. 48% of parents were very satisfied with the information that they received about their child's illness. And of those, 79% thought it was easy to understand, and 72% thought it was given in a timely fashion. And almost all parents wanted to know what was happening. In terms of treatment, 45% of parents reported being very satisfied with the information they got about how their child was being treated. They said it was pretty easy to understand, the majority, but only 10% said that it was given in a timely fashion. And 89% said that they did actually want this information. They wanted to know the details of how their child was being treated. In terms of daily care, 43% reported being very satisfied. So that's, as I mentioned before, the feeding, the bathing, and the changing, because sometimes it's not necessarily mom who is there to do all of these things. So you have to rely on nurses to be the ones to take care of your child. 78% said it was easy to understand, and 85% said they wanted this information. But when it came to parenting supports, only 19% of parents reported that they were told about services within the hospital that could help them to understand or cope with their child being admitted. But of those, all the parents who received this information said it was helpful. And of those who did not receive any information, about half of them said they would have wanted this information at that time. In terms of outside of the hospital, only 12% of parents reported getting any information or referral to services. And about 40% of those who did not receive any information said that they would have wanted this. They would have liked to have gotten some of this information and this support. So I think parents do want information, and they did get some about their child's illness, treatment, and daily care. And the majority felt that this information was relatively easy to understand. But this was not really necessarily given in a timely fashion, especially as it relates to treatment, and this could be related to maybe the high-pressure situation that is taking place and the quick decisions that have to be made regarding treatment. Parents are not really getting information or support within the hospital or outside of the hospital. And I mean, we want to know, is this the case that there are no services? But they didn't even speak about being referred to the social worker, for example, which many hospitals do have on staff, or there's nobody, you know, if there was a directory of organizations outside of the hospital that maybe we could just say, you know, we know that our health staff are overburdened, but nobody really spoke about saying, okay, you know, this has happened, or you might need some additional support. Here is where you can go to. So how can we increase supports for NICU families? And there are several mechanisms that we can use. So the NICU staff, I think that's really where we want to start in our training, when we are training our nurses and doctors and care workers. How do we incorporate a lot more of this information about how we support parents in this situation? And really, I think they're the first line of defense when it comes to support. They're the ones interacting with the families the most, and families are looking to them for information and support. This one is a little bit more expensive in terms of as a type of support, but really we want to be looking to the design of the NICU. We mentioned, for example, having the parent rooms, and then, of course, parent support groups and parent-to-parent support. I think this is extremely important and really could have helped parents in the NICU. So this could be having groups there at the hospital, or maybe assigning volunteer parents who have been through it before to just be there, even to man the dedicated phone line that I was talking about, or have some way to volunteers who can help to support parents in this situation. And then, of course, using online technology-based support. And so when I was reading about this, for example, they were saying that in New Orleans, when they had the hurricane and people had to be evacuated, and can you imagine, you talk about separation anxiety, you have a child in the NICU, and now you have to be evacuated to another state or something like that. They would be taking pictures and Polaroids of the child and emailing them to parents and maybe having video conferencing and so forth. So using technology to help support parents, get them the information that they need. And just having maybe online forums, parent forums, website, putting information for parents on websites about what to expect, or anything about what they can do in this situation. So I really want this work to continue. It's really my little baby, and I really think that what we want to do now is take a deeper look at the policies and programs that do exist. And maybe we need to start engaging groups like the National Parenting Support Commission in terms of how we can organize volunteer parent groups or programs, or do more training to help support parents who may have children admitted to the NICU. We need to do a survey of the units in Jamaica and the special care nurseries, to see really what facilities they do provide, and if they don't, are there some low-cost ways that we can really introduce some of these supports. And I would love to do some more detailed qualitative work with because a questionnaire is good, but sometimes it would be nice to sit down with groups of parents who have experienced this and really talk with them and get some deeper information about what they think would have helped them or can help them in that situation. And I just want to say special thanks to all the families who participated in JA Kids, and the interviewers who, when I just came at the last moment with Jody and Twan, everybody said, here, we have another questionnaire now for you to ask the parents who, they just jumped right in, they did their training, and we got the information very quickly. And of course, the Parenting Partners Caribbean, who actually really provided the funding for this sub-study. They paid for 2 additional staff that we needed to really ask these questions, enter the data, and get it analyzed. So thank you.
Thank you, Dr. Desai. We have heard some very useful recommendations for not only for people in parenting education, but also for parents. I'm a parent, and a lot of the information that's coming out of these sessions, I'm thinking, how can I apply this in my own life, with my family, with my friends' family? So take notes. We will be taking questions at the end of the session. Our next speaker, did I just say take notes? We'll be taking questions at the end of the session? Okay, I thought I said I'd take notes. Okay. All right. Our next speaker is Mrs. Twana Dinal, who is the Assistant Program Manager at the Department of Family Services in Fairfax, Virginia, and she will be speaking with us this afternoon on parental investment in young children. Ms. Dinal?
Good afternoon, everyone. One of the pros or cons, depending on how you look at it, of being last or almost last, is that a lot of whatever planned on saying was already said, so we should be able to go by fairly quickly. So today we're going to discuss the importance of parenting in early child development, which you've heard a lot of today, so you are all the choir for this topic. We're going to review data for JA Kids, but specifically the 18 to 22 months data. And then we're also going to start to talk about some of the policy and programmatic implications, thank you, Prof, which Cynthia had already started talking about. Now, not surprisingly, we all know that parenting is important for young children. And when we talk about parenting, we really want to make sure that we're being clear. We're saying mothers and fathers. They're both equally important in the young child. They're both equally important in adolescence and as these children grow up into adults. It's important to note also that mothers and fathers, while equally important, they have different styles in parenting, and that's fine. That's the way it's supposed to be. It's important to focus on the early childhood investment period in terms of the physical health, the emotional and behavioral competence, the social competence, and the cognitive competence. There are decades and decades of research that shows that the parent-child diet and the environment of the family are absolutely important for the early childhood development. When we're talking about parenting, we're talking about the knowledge, the attitudes, and the practices. And Cynthia really started to talk about some of that. The knowledge is the facts, the skills. The people who practice putting on the diapers already, that's their knowledge. The attitudes are the viewpoints, the cultural implications. I'm having a problem with that word. I'm going to stop saying it. The perspective and the reaction. And then the practice is, what are they actually doing with that? So yesterday, for some of you who were able to attend the opening ceremony, they talked about fathers, approximately 97% of them agreeing that breastfeeding is important. So that's the knowledge. There was an attitude, however, where approximately 16% thought it was unattractive. And then approximately 50% actually, in terms of the mothers, were doing breastfeeding and formula. So that's the actual practice of it. So really is trying to show that there is a discrepancy between the knowledge, the attitude, and the practice. And where we're coming up with the policy and the programs, we really want to make sure we're touching on all of these. And while we're talking about it in the Jamaican context, as has been mentioned many times before, there are subcultures within Jamaica, and we really want to make sure that any approach we come up with is going to really hit on all of our complexities. So in terms of the knowledge and the attitudes and the practice, we're really talking about the parent-child interactions, and then the time spent with the parents and the children, and the time we're really looking at the quality versus the quantity. Okay, and then we're here looking at in the different forms. So as mentioned before, the cultural aspects of it. There are limited research on parental investment on child outcomes in developing countries, which is why one of the many reasons why JKIS is such an important study. And we really want to make sure we understand parenting and its impact on child outcomes in Jamaica and the Caribbean, as it's critical to inform the development of an effective policy response. So in this case, while there's tons of research in the US, UK, and other higher income countries, we really want to make sure that anything that we're applying to Jamaica and the larger Caribbean is really about us. All right, so in terms of our second objective for today, really looking at the data, and as I mentioned before, we're looking at the 18 to 22-month cohort. And we're really wanting to look at the status of parenting and the parenting behavior in Jamaica, particularly as it impacts the girls and the boys. The parenting characteristics, and we'll talk a bit more in the data. The majority of the respondents were mothers, which is why we're focusing on mothers, but we really want to make sure we can get the fathers in it. So which parenting characteristics, example, maternal education, leads to better child development outcomes at 18 months? And then which parenting investments lead to better child development outcomes at 18 months? Prof already talked about the methodology, so I'm not going to spend any time on this. Just to say that in this, we had about 3,500 samples, and we had a focus group of about 1,000. If you haven't gotten a chance to go across to the exhibition hall, there is a sample questionnaire that has the questionnaire for the 18 to 20-month cohort in detail. So as I mentioned before, for the 18 to 22-month cohort, there were about 97% of the respondents were mothers. It was about 50-50 for the boys and girls, 51% boys, 49 girls. And as you may have guessed, they were aged 18 to 22 months. The mothers were about 26 years, the mean average. And as you can see, their education varies 17% for the primary. Secondary was about 48%, vocational 18%, and then tertiary, which was anything that captured everything from a university degree to a more advanced degree, for example, a law degree, that was about 17%. About 51% of the mothers reported that they were currently employed or going to school, and 16% of them were enrolled in the path. Andrea and others talked about the socioeconomic status in terms of how it was calculated with the proxy, basically how many durable goods did the mothers report having. So based on that, there were about 23% that were low, about 55% that were medium, and about 21% that was considered to be high. Prof. Samms-Vaughan went over this data already in terms of what was in the homes. The one thing that I would mention that Prof didn't mention was that for soft and cuddly toys, while 90% of them said they had it in homes, a lot of them were decorations. So they were on the shelves. So they're not necessarily being used. When we went into the homes, we saw a lot of that. So they had a lot of them, but they weren't necessarily using them as toys. And Prof already talked about the blocks and the toys that taught different things. So one of the other things that Prof already mentioned was that, once again, with the toys, they vary depending on the mother's educational status. So as you can see, primary versus secondary versus vocational, it definitely increased with the blocks, the toys that teach colors, shapes, and sizes, and numbers increasing dramatically from the primary category to the tertiary category, right? once again, with the interaction. So this is really talking about how the parents, well, in this case, the mother, spending time with their children, the positive play time. And Prof already talked about the singing, the reading, all that, and then what they do in the special category, okay? So negative. Not surprising, I'm sure, the Jamaicans are kind of big on discipline. So slapping, shouting, shaking, pinching, biting, those were the categories that were specifically looked at. If I recall the bite, some of the respondents for the biting was, if him bite me, I'm going to bite him back. So, and I'm seeing heads nodding like, yes, that sounds about right. But and I'm going to move to the next slide, but guess, would anyone like to guess if boys versus girls got more of the negative interaction? Oh my goodness, how did you know? So, and I really want, I'm really not trying to make light of this, but I want you all to think of, we've heard some data about men, particularly fathers, and their lack thereof in terms of being present. These are boys who are going to grow up to be fathers. And what are we doing with them at this age, right? So slapping and shouting were more or less equal between the boys and the girls. And then you're seeing the shaking, the pinching, the biting. And once again, these are 18 to 22 months old, right? You're seeing how it's different, really different between the boys and the girls. These are babies. Okay. So in the analysis that was done, we really looked at the maternal investment, that's the playtime, and we already talked about that. That's, for example, the singing, the talking, the doing something special. The ECD resources, that was the durable goods, for example, the washing machine, the cars. We looked at maternal characteristics, so that's the educational level. I'm sorry, ECD resources are the toys, sorry. SES was the durable goods, and then age, which was ultimately taken out to improve goodness of fit. And then we also looked at the child development measures, so that's expressive language, the problem solving, the personal, social, the fine, and the gross motor. In the interest of time, I'm going to go fairly quickly through the next couple of slides, but basically there was a strong correlation between the child's expressive language and the playtime with the mother and the number of toys. There was a strong correlation between the child's personal, social, and the playtime with the mother and the number of ECD-specific resources. Once again, those are the toys. And same thing with the child's problem solving and the playtime with the mother and the number of ECD-specific resources. There is also a strong correlation between the child's fine motor and gross motor and the playtime with mother, the number of ECD-specific resources, and the SES factor. Once again, in terms of the correlation, there was a strong one between the playtime with the mother and all the ECD outcomes. So in this case, it's the expressive language, personal, social, problem solving, the fine and the gross motor, the number of ECD-specific resources, and all the ECD outcomes. There's also a strong correlation between the maternal education and the child's problem solving, as well as the maternal negative interaction and the child's expressive language. In summary, there were limited toys for stimulating cognitive development in the home, which we've already seen in some of the other data. As Prof had mentioned earlier, though books were reported to be present, and a lot of these books were there because of the 9-month contact, they were less likely to be used by parents. The maternal education was showing a big impact on at 18 months. So basically, the more educated the mother, the better the outcomes for the child. Negative interactions were prominent, but unrelated to maternal education and gender defined. The boys were getting harsher treatment. Playtime with mother and the number of the ECD resources was positively associated with higher domains, higher scores in each domain, and the mother's level of education was significant in problem solving and gross motor domains, with children of tertiary educated mothers having higher significantly scores. So what does this mean in terms of the policy and programmatic recommendations? As Dr. Ashley had mentioned before, with the 1986 study, there are so much that came out of it. You know, it was the reorganization of the labor and the liver wards, the modernization of RGD, and Cynthia had also mentioned some of the policy and programmatic recommendations. And with all this data, as you can imagine, there are quite a few things that could come out of this. So basically, one main thing is how do we improve and increase the time and the commitment? So we want to increase the parents' awareness of the importance of spending time, quality time with the young children by engaging in meaningful early childhood development activities. And it doesn't have to be anything complicated. As Cynthia had mentioned earlier, some of the parents weren't speaking to the babies because they don't understand, which we know is not true. So something as simple as speaking with the child. One of the homes we went into, there was a young boy and his father. We brought some toys to the home and we asked the father to play with it, and it was such an awkward interaction. I said, what do you normally do? And they had some pebbles outside that they were using for building, and they just started flicking it, and the boy's eye just lit up. Now, while we're not recommending anyone go and throw stones at their children, I think what we really want to get away from this is, or take away from this is, we can easily use what we have. It doesn't have to be any expensive gadget, any expensive toys. The other policy and programmatic recommendation is around the skills and the knowledge. So we want to make sure we're providing parents with the tools required to effectively address the needs of a young child, understand the developmental differences of boys versus girls, because what we know in child welfare particularly is that if you're unclear about what is an appropriate behavior of a child, then you're more likely to be frustrated, and that's when you start doing things like him just doing it because I'm rude, and that's when you're going to get disciplined, when that's not always the case. And then creatively utilize materials and objects in their environment to effectively engage the young children, which I just spoke about. And then we also want to improve the social resources, i.e. increase the parents' access to supports which provides financial security, healthcare, and other social safety nets. Additionally, developing policies that protect time for parents, fathers, and mothers to form strong relationships with their young children. So we're talking about guaranteed paid maternal and paternal leave for a minimum time mandated by legislation. Policies requiring workplaces to have child-friendly environments, such as a breastfeeding room or in-house child development center. And then also thinking about ways to develop and expand systematic, multi-pronged programs which focus on the holistic needs of the child and the family. And then supporting policies that encourages integrating the building and support of an efficient cross-sectoral approach to early childhood systems. And as we're considering all these policies and procedures and programs, remembering that in this day and age, everyone has access to social media. So where parents are getting the information, not always vetted, not always true. So how do we incorporate that into any of our recommendations? Also, these children are growing up and they're getting their information from the social media, and then that's giving an added complication to that parenting child dialogue. And we want to ensure that families are a part of their solution. So it's all well and good that, as practitioners, that we can come up with the solutions based on the data, but we want to make sure that whatever it is that we're doing works for the parents who we're ultimately trying to serve. And I am done.
Thank you for that, Ms. Denal. It was very informative. Our fourth and final speaker this afternoon is Dr. Abby Harrison, who is from the Department of Child and Adolescent Health here at UWI-MONA, and she's going to speak on the adolescent parent in Jamaica. Thank you.
Thank you. Afternoon again, everybody. Let me first start by saying thanks to the JA Kids team for giving me extra work, but for giving me a really good experience. Okay, so my confession is that I love adolescents, and although that may suggest that I'm mentally unstable myself, it's true, I love them. So this paper really is in a developed and developing position as we go forward, so it won't have everything that we intend to look at, but as much as we can do today. So we know that about 15 of 135 million live births are to adolescents 15 to 19 years old. And although there is a decline in adolescent births globally, now in the last maybe 5 or so years, the global birth rate is still pretty high, so 49 per 1,000 girls 15 to 19 years, that's what our adolescent fertility rate is. And although in Jamaica we too have seen a decline, we're still above the average, and we're still pretty high at 59. And about 20% of children born in Jamaica have over the years been born to an adolescent mother. So if we look at this slide, and you don't need to look in too much detail, Caribbean, where the third one's going down, and it just gives you a graphical representation of how we've been progressing. So internationally, studies have shown that adolescent pregnancy has been associated with increased premature delivery, low birth weight infants, increased neonatal morbidity and mortality, and an increased likelihood of not having complete antenatal care. However, some of the studies have suggested that rather than maternal age being the most important predictor, that the level of antenatal care is more important. Locally, Young et al., including Helen Trotman and Minerva Thame, who are our neonatologists, looked at what happens to our adolescent mother's hair. And what they found was that really there was no significant difference between the adolescent and non-adolescent mothers. And when I say hair, I mean at UHWI, which is kind of a small microcosm of the patients that are seen across the island. However, they did find that adolescent mothers had a higher prevalence of urinary tract infections, a lower C-section rate, and positively there were no increased neonatal admissions. So what did we set out to do? We really wanted to know, are our adolescent pregnancies at higher risk than our non-adolescent pregnancies, and looking at it on a national basis. And is it all adolescent females that are at the same risk, or is it more in subsets? And what we decided to use as looking at these risk outcomes for today's purposes include prematurity, low birth weight, neonatal admission, and survival or death. I will not talk about the methodology. I think we've had a lot of that. So we're looking at 9,740 mothers. The mean age was 26 years with the range 10 to 52 years. And as we expected from previous data, just about 20%, so 19.3% of all the mothers happened to be 19 years or under, following our WHO guidelines for adolescent. So some interesting notes. Looking in this table, we're comparing adolescents, so 19 and under, and non-adolescent mothers. And as we expected, more women who were older wanted to get pregnant and were trying to get pregnant. But interestingly, almost 10% of the adolescents wanted to get pregnant. And then in the next line, you may find it a little counterintuitive that adolescent mothers, once they found out they were pregnant, regardless of whether they actually wanted to get pregnant or were trying to get pregnant, that they then thought that this was occurring at the right time. And that may not seem intuitive to you, but on the ground when you practice with them, they usually are, after the initial panic, oh my God, what am I going to tell my parents? They're usually quite excited about the prospect of having somebody that will unconditionally love them and that they can unconditionally love. More non-adolescent mothers were using contraceptives in the past, and that was significantly more so for using contraceptives in the past. But when we look at contraceptives around the time of getting pregnant, there was no difference between adolescent mothers and non-adolescent mothers. And that's really not very surprising to me. I don't think older adults are any much better at being safe and healthy in their choices than are the adolescents, and they have no biological reason to do that. And the adolescent mother was more likely at this point to be still in a relationship with the biological father of the child. We have not looked at the longitudinal stretch to look and see what happened at the 9 to 12 months or the 18 months point. Now, when we look at their level of parenting knowledge, about 20% of our adolescent mothers said they knew nothing about pregnancy. Not surprising. Or is it surprising, since we have HFLE in our schools, and so they really should know quite a bit, so that may speak to what is happening there. But they went on to learn quite a bit. So the first line is before pregnancy, then the second line is after pregnancy. And so you'll see knowing nothing dropped significantly in the adolescent from 17% to 3%. And for both groups, the healthcare provider was their best source of information. When we look at lifestyle choices, things that approached significance, one would be getting rest. So the adolescent got more, just about, they were like about P-score of 0.06. But maybe adolescents are generally better at getting rest than adults because they have less demanding times. But the adolescent was a little bit less careful about what they did and where they went than the non-adolescent mother, and they were also less likely to be attending regular antenatal care. But I am happy to see that a high percentage, so 90-odd% of all our mothers were getting antenatal care regularly. Although adolescent mothers, similarly to non-adolescent mothers, intended to breastfeed when it first starts, you will notice that when we get to the 3-month part, which sort of talks about persistence and consistency, they fell off in comparison to the older mothers. Interesting attitudes that we saw towards breastfeeding, some of it quite intuitive. So adolescents were more likely to think that breastfeeding was going to restrict their freedom. They were not as aware or didn't feel the same level of interest in creating a special bond as a result of breastfeeding. But everybody thought that, 97% of persons thought that breast milk was the best option, but more so in the non-adolescent mother. Interestingly, 50% of mothers thought that bottle feeding would allow for more care. So I think we need to teach our mothers how breastfeeding does not interfere with paternal bonding and show them how the father can continue to be involved in that. And there were some mothers who felt that if you don't breastfeed, then you're not a good mother. Okay, so in terms of biological father's involvement, there was really no significant difference between the two. And I would say, apart from antenatal visits, I think our fathers were very involved. And I'm not surprised because fathers don't like going to the doctor, so that's why they don't go to antenatal visits, is my suggestion. I'll skip that in the interest of time. Now we went on to look at a few other things. So the experience of their antenatal care, so how satisfied they were with their antenatal care, was pretty much similar across the board, except that adolescent mothers felt that they needed more time with the healthcare provider to finish discussion. Or felt that they had sufficient discussion, There once again was no increased risk of UTI in this larger sample or in STIs. However, this may be a limitation for us because adolescents did have more vaginal discharge, and we don't have all the fancy testing that, we could identify whether this is chlamydia or so, and we know that those don't culture very well, so we might be underreporting the STIs in pregnancy. I will skip over the Edinburgh postpartum depression, as a lot of that has been done before, but sufficient to say that there was no significant difference between the two groups, and that similar to what was found before, if they were still in a relationship with the biological father, they were less likely to be depressed. And if you had pre-pregnancy anxiety, so at the beginning of your pregnancy, if you worried about your pregnancy, you were more likely to have postpartum depression. Now we look at some of the other pregnancy outcomes. So there was no real difference in survival rates between adolescents and non-adolescents. However, there was a slightly higher rate of preterm delivery in the adolescent mother and a higher proportion of low birth weight infants. When we look within the adolescent cohort now, remember our second question was to see whether there's a subset that's doing better or worse. And when we look at a lot of things that we checked on, similar in terms of trying to get pregnant, thinking that pregnancy was at the right time, using contraceptives, all of those were similar. And age of first sexual intercourse, although about 2 years different, was not statistically significant, but I would say to you, I would think it is clinically significant. Within the group again, the younger 15-year-olds, under 15, so the 10 to 14-year-olds, the babies were more likely to not survive, slightly so. And although there is a big difference in the preterm, and I rechecked it and rechecked it, it did not come up as statistically significant, but we'll look into that more. And as expected, there were more low birth weights in the under 15 age group. So in conclusion, our older mothers are more likely to attend antenatal care visits and express the desire to breastfeed longer. Adolescent mothers did have a higher prevalence of vaginal discharge, but not of STIs or of urinary tract infections. And adolescent pregnancies were more likely to end prematurely and to end with delivery of a low birth weight infant. Adolescent mothers under 15 years had an increased prevalence of low birth weight and a lower survival of the infant in comparison to their older peers. So our recommendations coming out of this and a way forward, with the recognition that the under 15-year group is at highest risk of a poor pregnancy outcome, I think we have to renew our focus on this cohort. And I think we have to look at how we approach offering and giving them advice about sexual and reproductive health and keeping them protected from pregnancy by way of contraception. We also want to further explore the influence that the psychosocial and socioeconomic factors may also have on pregnancy outcomes in the adolescents. So I'd like to acknowledge the super team, JA Kids, and of course the study participants, and the team members within the adolescent pregnancy group, which are listed here, and Dr. Olugbuyi, who was very helpful in terms of the statistical analysis. Thank you for listening.
All right, ladies and gentlemen, we have come to the question time. We're going to try and take a few quick questions before we break for lunch. I would first like to thank our 4 panelists for your very informative presentations, that we can certainly use the evidence to inform our policy and programmatic interventions as well as our advocacy efforts. And I'm going to take a few questions and then break for lunch. Any hands? Please raise your hand if you have any questions for our panelists. Yes?
Yes, Abby. The last statement you made was that the under 15s have a higher risk of poor outcomes, and so interventions regarding sexual and reproductive health issues, contraception, which doesn't match what our current policies regarding providing sexual and reproductive health support for that age group. And you know that I've done it before in my own adolescent clinic, referring like a 16-year-old for contraception. She doesn't get it. She says, "Miss, the nurse, I'm too young to get it." So address that.
So our law does allow them to get it from 16 and up, because that's the age of consent for medical and surgical care. But yes, and maybe I'm opening up the hornet's nest, but I do think that if we recognize that culturally our young people may be exploring and experimenting, which is a normal part of the adolescent phase, and so long as it's not an inappropriate relationship where there's a significant power differential, then I think we do have to keep them safe. So I do think abstinence is our primary goal for young people, but I think everybody in here would recognize that when you tell somebody not to do something when they're an adolescent, that's when they actually want to do it. And I think a lot of healthcare providers recognize that a lot of the under 16s are sexually active or are at high risk of becoming sexually active, and not necessarily in a predatory way where it's a 50-year-old man that's grooming them, but it could be a 14-year-old with their 16-year-old girlfriend or boyfriend or whatever the case it is. So I think we have to look at both sides of the coin and keep them safe.
Yeah, I think you could probably do is risk aversion. Let them know that it's dangerous for them to get pregnant.
So risk aversion has not really been shown to work with adolescents, though.
Okay. Any more questions? Yes, sir.
It's a question for Tawana, really. about how to engage young women from poor social backgrounds in anticipatory guidance about the development of their child. And I was very impressed seeing some evidence from India where they used a weekly text message about what's coming next to sort of anticipate and give advice. And given the prevalence of cell phone usage, do you think that would work here?
So I think it would work here. I'm not sure. Has there anything like that been tried here, Charlie?
No, but I can add, Professor Eamon, that is one of Professor Samms-Vaughan's dreams for us to develop an app where, you know, to develop information on child development so it's one of the things that she has in the works. And as I said yesterday, you know, sometimes we think that this is never going to happen, but she finds a way. So it's one of the things that we would like to see develop.
And I know Prof is already looking at stuff like that, and one thing that we definitely want to make sure we do is that anything we're doing, whether it's a text message or social media, that it's in language that's understandable, because there are times when we're well-intentioned, but the language is very complicated and no one understands it. And particularly if we're dealing with a clientele that is low literacy, how do we make sure that perhaps it's more infographics than less text, that kind of stuff. So there are so many ways we could be creative about it, and just being clear that we're targeting the people, our message is reaching our target.
Any more questions? Yes, sir.
Thanks. Good afternoon again. Question to Dr. Abigail Harrison. With regards to your investigations, I wanted to find out if any of the participants in your study were in contact with, that is those under 16, in contact with the Women's Center, and if that had any significant effect on how they dealt with or thought about prenatal care, etc.
That's a good question. I don't have the data as to whether they were with Women's Center or not, but generally speaking, once they're delivered in a health center, where most of them would have been, once they're under 16, it's a mandatory reporting. So it's not that you can really hide that one or skip that report, because pregnancy is self-evident. So I would suspect that most of them would have been referred. But yes, that would be interesting to look and see if they had been there, because that sort of social support would also be very useful.
Any more questions? Well, with that said and done, I would like to thank our 4 presenters for a very informative session. Panel, thank you very much, ladies. A couple housekeeping announcements, it's fine. Yes. Lunch will be served in the same area where we got coffee break, but you're not allowed to have lunch unless you're going to come back after lunch. No, but lunches will be served there as well. We have the exhibition space that we're encouraging everybody to make sure that you go through and take in all that there is, very rich information. And I would personally like to make the point that it was touched on, but all of this information that we are getting, I am a human and child rights advocate, and all this information that we're getting, we talk about what we need to do. The how of what we need to do is equally important. And it came to mind with you, Dr. Harrison, with your young people, the best way to package those messages is to engage them in the development of it so that it's meaningful to young people, and to use culturally appropriate. Quite often we like to adopt and adapt, but we really need to make things culturally appropriate for our people in terms of the visuals as well as the language. And on that note, thank you and enjoy your lunch.